time flow of various antibiotics being discovered. So when was carbapenem resistance or MBL discovered? So you can see here it was sometime around 1991. Okay, so while they were doing research on carbapenems, they also realized that there is carbapenem is like MDL. Okay, it's only that its emergence in pathogenic organisms and its spread everywhere happened almost 15-20 years later. And what we can see from this is that if we use antibiotics, there's going to be antibiotic resistance, right? So the challenge is how to prevent spread of this. So antibiotic stewardship is how to restrict the spread, not to restrict the emergence. Emergence is a natural phenomenon. The spread is probably something which we do. So what is antibiotic stewardship? So there are various components. So I'll just read this out. It says optimal selection of the drug, the dose and the duration. Next it says that whatever antibiotic you use should have the best clinical outcome for the purpose that you are using. So either it's for treatment or for prevention. Okay, minimal toxicity to the patient. And what antibiotic stewardship says is it should also have a minimum impact on subsequent resistance. In other words, what we want to do is strike a balance between what is good for this patient and what is good for future patients which we are going to treat. So that is the crux of antibiotic stewardship. So this is, there is a nice book which is published by the CDC on outpatient antibiotic stewardship, and this is what is on the cover. It says antibiotics should be handled with care. So what is optimum treatment of a patient? So the first thing is no misuse. What is misuse of antibiotics? Unindicated. That means there are very few prophylactic indications for antibiotics. The second is an antibiotic has no role in viral infections, right? Next is no overuse. So what is overuse? An antibiotic is indicated, but we use multiple antibiotics, prolonged use. We use a broad spectrum antibiotic when a narrow spectrum antibiotic could have worked. And we directly go for reserved antibiotics when we see a patient. So all of this would be overuse. And last is no underuse, which is also important. That means you've chosen the right drug, okay, but you are worried about nephrotoxicity, so you use an inadequate dose, or you use it for a short duration, you give it only for 3 days and then stop. So this is something which is underused. So any of these is not appropriate and is not going to get the result which you want. So the question is, antibiotic stewardship came in almost like 10-12 years back, okay, and it mainly came for inpatient practice because that is where we were seeing maximum number of antibiotic resistance, ESBL and everything else, okay, but this is how big the opportunity is. So the US data tells that 80 to 90% of all antibiotic usage happens in outpatients and not inpatients. Okay, similarly, if we look at costs, the ones which we use in inpatient are expensive, but 60% of all antibiotic revenue comes from outpatient practice. Okay, they also found that 30% are unnecessary use of antibiotics for non-bacterial infections, so either protozoal or viral. Second is wrong selection, wrong dose or wrong duration was seen in 20%. So this is the opportunity of balancing what is good for this patient versus what is good for future patients. So these are some other studies from various countries. So this is data from NHS in UK, okay, which says antibiotic prescription is higher if a patient comes on Friday. Okay, then if the patient comes just after a visit by medical representatives, okay, then patient pressure. So patient tells you, "Nahi sir, 3 दिन हो गया, कुछ अच्छा antibiotic दे दो." So patient asks for it. Then there is this fear of losing a patient. Then out of hours consultation. So if a patient rings you up when you are very busy, doesn't come to your OPD but rings you up and says, "Sir, 2 दिन से बुखार है," then you are more likely to prescribe an antibiotic. Okay, and lastly, perceived exceptional circumstances. So I had a patient last week who said that I am flying on a vacation day after tomorrow, I have a sore throat, please give me some antibiotics. So, something like that. Okay. This is again interesting from the CDC. It says that when they studied a whole lot of doctors, there were 20% of doctors who prescribed 80% of antibiotics. Okay, so the key is to not fall in this 20%. Okay, so we'll just skip this. So let's see antibiotic stewardship in specific infections. So a lot of people have habits of taking pictures of slides. So if you have to do it, the next 3 slides are things which you should probably photograph. Right? So first is antibiotic stewardship in respiratory infection. So this is the commonest reason for antibiotic prescription in outpatient practice. Okay? So antibiotics are prescribed for 80% of patients with rhinitis and 60% of patients with pharyngitis. In adults, only 10% of these are actually bacterial, all the rest are viral. In children, it's the other way around. In children, there is a lot of bacterial pharyngitis, so this is only for adults. Okay, so what is the recommendation? First, start symptomatic treatment. Second, prescribe antibiotic if you don't want the patient to come back to you, but tell them to take it only if the symptoms don't improve in 72 hours or if the sputum turns purulent. Okay, so by doing this, you are prescribing an antibiotic but telling the patient don't use it. You can even go to the extent of saying that after 3 days, let me know how you are feeling. Right? So that is the next thing. Okay, next is urinary tract infections. So uncomplicated cystitis, which is characterized by dysuria but no fever or loin pain, is very common in females. Okay. However, in females with dysuria, dysuria is just burning or pain during passage of urine, no other symptoms. Only 50% of these are actual bacterial infections. Okay, what is the rest? So the rest might be vaginitis, urethritis, whatever. Okay. However, if the dysuria is associated with frequency of micturition and fever, then there is a greater than 90% chance of it being actually a bacterial urinary infection. Again, if a patient comes with dysuria alone, there is rarely a need for immediate antibiotics, right? If there is no fever. So confirm the diagnosis by microscopic examination of the urine, and you will be surprised that in more than 50% of these patients with dysuria, urine examination will be normal. There are no pus cells. Okay, even the culture may be negative. If you have to treat, then treat with basic antibiotics like cotrimoxazole, nitrofurantoin, norfloxacin. Okay, if there is dysuria but no frequency, another diagnosis is urethritis, especially in males. So if there is urethritis, this is more commonly because of chlamydia, mycoplasma, urea plasma and gonococci. So the standard antibiotics which we are using, okay, like coamoxiclav or sometimes people will use cefuroxime or something like that. These are not going to act against these. The drug of choice for this is doxycycline, right? So it's not like dysuria start antibiotics. You need to sort of go through this whole protocol, and then you'll end up giving antibiotics to lesser patients and probably giving the right antibiotics. Next, what is the role of stewardship in GI infection, that is namely acute diarrhea? Okay, so as per Harrison's textbook, 80% of acute diarrhea is self-limiting in 24 to 48 hours. Okay, the so-called food poisoning. Patient tells you, yesterday we had gone out, I had chaat and today I have loose motions. So what you need to do is give symptomatic treatment, because most of them are self-limiting in 24 to 48 hours. So what should be the treatment plan? So basically in mild or moderate diarrhea, symptomatic treatment and oral rehydration. When should antibiotics be given? So as per CDC as well as Harrison's textbook, it says antibiotics are to be given only if there is fever more than 101, if there is profuse diarrhea to the extent that you expect this patient will get dehydrated, and thirdly, if there is blood and mucus in the stools. So blood and mucus in stools effectively means colitis, right? It is not like a small intestinal diarrhea. If there is colitis, you need to think little further. Is this amoebic colitis or is this bacillary dysentery? And the way to differentiate between this again is to see if there is fever. In amoebic colitis, fever is extremely rare. Patient will have several motions, there will be blood and mucus, but there will be no fever or very little fever. On the other hand, if the patient has fever, chills and blood and mucus, it's almost certainly bacillary dysentery. And accordingly, the choice should be either to use antibiotic or to use an anti-amoebic drug. Okay? So there is, if you give a little bit of thought and ask just one more question to a patient who has diarrhea with blood and mucus, fever or no fever, then you will probably avoid using a combination. So use a specific drug rather than using a combination where the history tells us what is the diagnosis. So to come to my last slide, antibiotic stewardship means ideal use of antibiotics. That means first, optimum use. That means no misuse, overuse, underuse. We've seen what these are. Second is when prescribing antibiotic, remember the 4 Ds. Okay? So the right drug, the right dose, right duration, and as Dhanashri said, importantly, de-escalation. So you may start with a broad spectrum antibiotic. Once you get the culture or once you know what it is, then consider stopping the broad spectrum antibiotic. And minimize the use. How do you minimize use? First is follow the guidelines. Second, very important, is rapid diagnostic test. So if you have a patient who says that 2 days I am having fever with chills, okay? So there are rapid diagnostic tests which are available for dengue, which are available for malaria. If these are positive, then the results are available in 3 hours, 4 hours. At least you don't need to give this patient antibiotic upfront. You just tell them that you take paracetamol, get these tests done and let me know the reports. If these reports are negative, then okay, then you have to use your clinical acumen to figure out what it is. But at least a positive test for malaria, dengue, which is common, would avoid the use of antibiotics. Again, start symptomatic treatment, and if you have to give a prescription for antibiotics, it's called a backup prescription. So that means what you do is you give the prescription, but tell the patient don't start this. After 2 days, call me up again, let me know what is happening. So that is a backup prescription. So that in short is briefly about antibiotic stewardship in outpatient practice.